which is used for support of the balance. The body is then lifted with the calf musculature to the maximal height that the patient can achieve. And this is repeated until pain is felt in the calf musculature, and then followed by 5 extra repetitions. The training concept is easy to perform and self-regulatory, since the instruction to perform 5 extra calf raises after that bit of pain will remain unchanged with any improvement. Since the weight of the body of the patient is applied, the training sessions can be performed at home without supervision. Additional equipment, of course. The instruction is simple, and thereby the compliance can be expected to be good. We hypothesize that 5+ training increases walking ability in patients with intermittent claudication without changing blood flow. 29 patients were included. These patients were randomized to either a group of 5+ exercise 3 times a day for 8 weeks, or a walking group. The walking group was instructed to walk at least 30 minutes 3 times a week. The content of the instruction was to walk near the pain threshold and slightly past it, followed by rest. And patients were not contacted during this 8-week period to be able to judge the degree of compliance. Walking ability was tested with a 6-minute walking test, giving information about the pain-free and the maximal walking distance. Furthermore, a treadmill test was performed. It consists of the patient walking at a constant speed of 3.2 kilometers an hour, with the treadmill gradually increasing. On the treadmill, the onset of pain and the time at which the test had to be stopped were tested, being the variables claudication onset time and peak walking time. Hemodynamics of the lower extremity was assessed by the use of the ankle brachial index and plethysmography, measuring maximal blood flow. An activity monitor was placed on the arm, which was worn for the whole study period. Participants in both groups registered each evening the total counts of activity registered by the monitor. Comparison of the average counts of activity per day in the first week were compared to the average count of activity in the last week. To monitor compliance, patients were given a training diary. The calf raise group registered the amount of calf raises performed during each session. The walking group registered the time and content of each activity. Compliance was based on whether participants followed the instruction of exercise. Pair-T test was used for statistical analysis, and statistical significance was indicated by a value of p below 0.05. We found that the instruction of exercise increased all variables of walking ability on a statistical significant level. Pain-free walking distance increased by 44 meters at average, and maximal walking distance increased by 99 meters at average. On the treadmill, claudication onset time increased by 120 seconds and the peak walking time by 100 seconds. There were no significant changes in the walking group, and hemodynamics did not change in any group. There was no change in activity in the 5+ group, and the compliance was good. In the walking group, the activity was reduced, and the compliance was less. So our conclusion is that 5+ increases walking ability in patients with intermittent claudication after 8 weeks of exercise without changing blood flow. In Norway, the Norwegian Society of Vascular Surgery has now planned a multi-center randomized clinical trial, which is nationwide, to further study and examine the potential of 5+ exercise. Thank you.
Thank you, Michael. Any question? This time of the day is still difficult to make a question.
Yeah.
I understand the comparison between the two groups, intervention and non-intervention. They are quite different, no?
Yeah, in the end they are different. But in the start it's not different because it's only a simple instruction of exercise which are given to a patient.
No, the base characteristics of the groups.
What did you say?
When a group walked
Walking exercise for 5
yeah, at the beginning, one of the group did distance, I think, 200 meters superior to the other group.
No, that's very important to. This study was there was an extra thing which was the reason for the power analysis. We also looked at the effect on the mitochondria and the leg muscles, so we took a biopsy. So this study is relatively underpowered to be able to say whether 5+ is better than a walking group. That's the reason that we are doing this now. So what we can say is that in this group of patients, 5+ worked on a statistical significant level. Walking instruction did not work on a statistical significant level. But it's also important to know that everything of exercise can help some patients, while other exercise does not help patients. Is that
Yes, I agree.
Yeah.
Any further question? No? So?
Are there any costs associated with this kind of exercise? Have you estimated?
It's only the consultations cost, so there are no costs. And it only takes, half a minute.
Yes.
Nilsson, Sweden. May I ask you, thank you anyhow for the study. Are the patients in your study subject to any other medical workup, for example, lipids or diabetes care or smoking cessation or anything? Thank you.
For this study, there was no other initiatives besides the standard treatment. So, meaning that they were not operated during the study. Most often they are already started on lipid-lowering drugs. I think 90% has one of the lipid-lowering drugs they are using. They are already using antiplatelet drugs. Because at that moment I worked in vascular surgery outpatient clinic. That's where I included the patient. So the standard therapy was already initiated. And it's an instruction of exercise. It's not something to change the standard therapy. It's something that is the reason that we do it is just we want to represent reality.
No more questions? Thank you, Michael, for your excellent presentation.